So Mike had to leave for the airport, and this is a case that we shared. So we kind of had a unique clinic. We would be in clinic together every Tuesday morning, and we'd have about 25 people scheduled. Not all of them Mike had to see, but especially these people. I would see, quite frequently looking for, subtle changes or other treatment things. So probably for 5 years, we've done different versions of endovascular deep venous arterialization procedures. At first, we were, it's kind of off the shelf, like a Lego kit. We were, we're doing the procedure, and then probably the last 65 or 70 that were done were with the lymph flow technology. So this is a guy that his son was a PhD at UT Southwestern. So he's an 85-year-old gentleman that had left foot pain and dry gangrene. He was status post left SFA angioplasty, and he had an arthrectomy and just threw embolisms to his feet. And I'll show you his picture in just a second. He had history of diabetes. He had anemia. He had, everything that you want your 85-year-old father to have. He was still a household ambulator. He only spoke Korean, so his son was always with them to translate. Really pretty positive, functional guy. His exam was pretty unremarkable, except no foot pulses to his feet. And this is what his feet looked like when he initially presented. So saw this guy in the hospital, and Mike said, "Hey, you want to try to save this guy's leg with me?" And I said, "No, not really." And I was like, "Wow, that looks pretty bad," but it gets worse. I mean, all of this dies, and all of this dies. So, he talked to I forget who did his procedure, maybe one of the interventional radiologists at an adjacent hospital, and see, that looks pretty good. It's gonna die more. So, our discussion was really with the patient and his son. Do you want to attempt a revascularization procedure, or should we just do a below knee amputation? Everyone was telling him at the other hospital, this is not going to survive. We could try this DVA procedure. He explained to the patient and the time frame, which is a long window to get revascularized or to get angiogenesis when you do this. Or we're going to do the DVA, allow the foot to demarcate. There were no local signs of infection. It was just dry, dead tissue, and they wanted to try to save his foot. So this is his angiogram. Pretty impressive, huh? This would fall under the no vessels near his foot category. So this is truly a desert foot. I mean, this maybe gets to his ankle. And I think the importance of this, there aren't a lot of studies that look at vessels that cross the foot and limb salvage. This is a small study from actually the VA in Dallas that, basically shows if you have no vessels to your foot, like this guy, 100% of the time you lose your leg. If you have one vessel, 56% of the time you lose your leg. Et cetera, et cetera. So this guy was really in the 100% you're gonna have your leg amputated category. And you guys, Mike talked a little bit about DVA earlier. It's kind of the buzz. If you're gonna, I really think this is a great procedure. You need to have a handoff of someone that's going to babysit these wounds, and there's a little shift in your thought process from doing this procedure and doing the DVA and then doing foot procedures that are traditionally thought. And if we made the mistake of when we first were doing these, we were doing them on really sick people, and we had several people die, several people that lost their legs because their foot just necrosed. And then we kind of dialed back and weren't going to try to save everyone. So all of the patients we did, we used our saphenous vein for the DVA. And so this is like from no vessels to his foot to this is what the DVA looks like when it's initially plugged in. I guess that doesn't run. So this is his foot after he had his DVA. Look, it got worse. I mean, it's black, all the way to his heel. The dorsum of his foot is like, it's dead to the top of his foot. And I was like, okay, it's not infected. We have time. So I'm going to show you a series of pictures that are probably at 3-week intervals. So I like iodosorb on these on the wound edge. Everything was really dry. He had no local or systemic signs of infection. His labs were normal. He was comfortable. Oh, no, wrong way. So this is what he looks like 3 weeks from the DVA. No change, right? Really, really unimpressive. He has a little bit of the wound on the top that kind of peeled off, and he had pink underneath. And this is him, another 3 weeks, a little more granulation tissue, right? Nothing on the heel has really changed. 3 weeks later, more of this is kind of peeling off. He has granulation tissue instead of just dead tissue. So Mike and I are quietly doing high fives and saying how awesome we are. This is 3 weeks later. So now this peeled off all the bottom, this dry, superficial gangrenous tissue peeled off. And then this is, the next 3-week period. So I think one of the things that forced our hand was the top of his foot got a little bit wet. And so we decided we're going to take him to the OR. We're going to debride this. He's going to have a transmetatarsal amputation. We usually stage this. And I like to cover these with Integra, vac it, and then, usually these people get their DVA tuned up. So one of the reasons I see them on a weekly basis or, every 10 or 14 days is to look for those vascular changes. And it's subtle. It's someone that when you come in and go, his foot was warm last week, it's cold this week. Michael schedule them, take them back, and kind of tune up their DVA. And a lot of times so here's kind of the photo of that. So you can see he has this, Mike had a really beautiful series that he showed earlier today that was several intervals where he did a repeat angiogram. We don't have that in very many patients, but almost everyone goes back at 6, 7, 8, 10 weeks, and they get their DVA tuned up. So you can see he has proliferation of these unnamed vessels, and this is about 8 or 9 weeks after the procedure. This is not him. So this is what his foot looks like. He's not bleeding very aggressively, but all of his wound looks granular. There doesn't look like there's any infection. We take all the dead tissue out. We cover him with Integra. We vac over the Integra. And then we do a skin graft. 3 weeks later, he gets a skin graft. So he really had all of his wound took except for the lateral side of his foot. And initially, so we just debrided that. We dressed that with iodosorb. He had a couple of places from his shoes that he ulcerated on. He had a area on the side of his foot, but he would heal, and then if he wore the wrong shoes, he'd ulcerate again. So I think there's a couple things we learned about their surgical course. If they're infected, then your hand is forced. You do an IND first. We leave all of these open. People are tempted to close these, but when you first do the DVA, the only flow you're going to have is venous flow or AV fistula flow on the bottom of the foot. So you'll have no flow on the top of your foot, and the top is going to die. So if you close it, your wound's going to necrose and it's going to die. Everyone wants to close these, but there's one vessel to the foot. So we had a couple of these fail, and Mike said, why don't we vac these? And I'm like, okay, because what we're doing isn't working. So we started vacuuming people early, really had nice granulation tissue, but you have to wait 8 or 9 weeks to get angiogenesis that's going to supply the plantar wound and the dorsal wound. And I think if you try to rush this, and this guy was probably 3 months before he went to surgery, or back to surgery to have this skin graft. But we have, I think what Mike showed today was the results of 63 people. I think we've had one below knee amputation. We haven't had any deaths. And I think probably 40 of those people have a year follow-up. I mean, last time we talked, we were working on a 6-month follow-up for everyone. So I think the biggest problem in the community, when I've talked to vascular surgeons or interventional cardiologists that are doing this, is the handoff, the person that's doing the surgery, and they want to treat it like it's a regular infrapopliteal bypass that you have a couple of vessels that are working to the foot. They want to debride it and close it. And I think your wound's going to necrose if you don't wait for the new vessels to grow. Same thing when Arthur was talking about the distraction angiogenesis. You're going to do that procedure and it's going to take you 2 or 3 months to get new blood vessel growth. And we have, several patients that have gone back and have had a second angiogram. And you really get a robust number of the unnamed vessels on the top and the bottom of the foot when you do the distraction angiogenesis. So, I mean, this guy was a household ambulator. He had house shoes. We tried to get him, to have a custom-made insole and a shoe, and that really wasn't working for him. But we would dress these small wounds, and he would heal in a matter of a few weeks. So I think we're still looking at what the long-term durability of this revascularization procedure is. I'm sure it has to do with how long that AV arterialization is successful. So you can see shoe-related injury on the back of his heel. So it's the same as all the other people that you revascularize. You're not going to fix their neuropathy. We're probably going to make their biomechanics worse rather than better. And so it's the re-ulceration that we're going to have to be vigilant about, and that still I think that the people that are prosthetics, are prosthetists, aren't super about doing this. So it takes a lot of attention on our part. So with that, I'll finish and thank you.